Can everyone hear? Good.
Yeah, yep. Sounds good.
Good.
Exactly. I know. I have you signing your spot.
Okay.
Hey, good.
So you'll keep us posted on quorum?
Yeah. Right now I have 10.
That's a quorum.
All right. You good if we get started?
Oh, if that's what you said. If that's what. Sorry.
Just want to make sure you're ready. We can't do much without you.
No.
All right, good morning, everybody. We'll open the July MAC meeting. Don't think we need to do introductions because everybody in the room has been introduced before. And we have no consent agenda items today, so we can breeze right through that. We do have 3 months worth of meeting minutes. I think April and May were sent out with the agenda. June, Friday? Okay, it's all the same, Friday, Sunday. Has everybody had a chance to look through those meeting minutes? All right, so let's just sort of take it in order. Do we have any comments or anything for the April minutes before we look for a motion? Hearing none. Could we have a motion for the April minutes, please?
So moved.
Thank you, Kelly. Kelly moves to approve the April minutes as submitted. Do we have a second?
I second.
So we have Deo Janae. Sorry. You have a preference, D.
Deo Janae.
Okay, sorry. So D has seconded. Any discussion? All in favor? Aye.
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 Holly says yes.
Okay. I feel like I only heard like 4. Are you getting more in the chat?
Just Holly said yes.
Okay. Other members, if you could register your aye or your nay audibly, that would be great. We've only collected about 4.
Aye.
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 Thank you. Okay, moving on to May. Has everybody had a chance to review May? Any comment or discussion of the May minutes before we look for a motion? Hearing none, could we have a motion on the May minutes, please?
I make a motion to accept the May minutes. This is Joan.
Thank you. Thank you, Joan. Do we have a second?
I'll second.
Thank you, Brooke. Any discussion? All in favor?
Aye.
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 Did you get all those, Kristen?
Yep.
Okay, great.
Abstain. Abstain.
All right, so moving on to June. I know we've had a little bit less time with the June minutes. Any questions or discussion before we look for a motion on June?
I actually have a clarifying question about the alternates. You have on there, and maybe this is just stylistic, but you have listed on there at least the alternate for CS&I, but then I was also there, and you have me as the members. Are you counting people under the alternates line, even though the primary member is there?
You see the minutes for June.
I don't have the.
Yeah, I think I know what you're saying. Like, I think we do tend to record if the alternate and the member are present, both of
Okay,
them
all right.
in the category. You know what I mean? It's like if
Yeah.
they're an alternate, they'd be in the alternate line.
Yeah, if they're,
Okay, I
if the
just wanted to
alternate's
be sure it
present, then
wasn't
I put
error.
in the alternate.
Okay, great, thank you. That was the only question I had.
Oh.
Thank you. So can we get a motion for the June minutes, please?
So moved.
Thank you. Do we have a second? Brooke, thank you.
Who was it?
Steve?
Oh.
Brooke was second. Any discussion? Hearing none. All those in favor?
Aye.
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 Any opposed?
Aye.
Any abstentions? Okay, ayes have it. Thanks for all your work getting those out.
Thanks for your review.
Hi, so we currently have one item as an agenda item for future meetings. This came up a minute ago, and I think it's coming later this summer. The report out on the workforce strength for direct support workers. Do we have any other suggested future agenda items?
Yes.
Kelly?
With the changes in the bill at the federal level and things such as 6-month redeterminations, I know it's not till December 2026. They just want to make sure that we're keeping an eye on what those operational changes are and what they'll look like here. in reviewing the changes to the bill and some of the things that could impact the workflows at a provider agency. Things are also coming up like, is there any opportunity to revisit workflows within the department that we have to engage in very specifically, the submission and activation of auth reps. So we find that sometimes we have to submit all that paperwork 5 or 6 times. And it's not the lost paperwork, it's inconsistency in application of what the forms are for. So sometimes they say, no, you can't be an auth rep with this form, you have to submit these forms with it. And then we come back and they say, oh, you don't have to submit those forms, those don't get you anything. And so just sort of putting it out there as we're making changes, like, let's just say 6-month eligibility for REDs. Can we look at it from soup to nuts? And I know, it's a funny request because I say we, but I mean you. Because it's not for us to do.
Sure. I mean, I would echo that, and we may want to consider sort of keeping as a regular agenda item, sort of like updates on these implementations. But, like Kelly, OPG processes applications and REDs for over 1,000 people all year long. And if we move, as we are led to believe, into a more administratively difficult model, that has implications for us for staffing and other things. So we'd rather be prepared ahead of time rather than flat-footed and impacting people's eligibility because we weren't sufficiently prepared. So, so maybe, when we prepare our next agendas, we can sort of think about how we keep that top of mind as things move closer and closer to implementation.
Yeah, I think we're going to talk a little bit about that later today as well. Yeah. On a high level.
Great.
Will you be talking about the state level changes?
Yeah.
As well?
Yeah.
Okay. I'll save my questions.
You were not alone. I was getting text messages this morning. Are you going to talk about blah, blah, blah today? Yes, we are. Okay. Any other suggestions for future agenda items?
Holly?
Hi, Holly.
Yeah, hi, to piggyback on what Kelly just brought up, the changes also at the state level with the premiums, the increases in copays and the work requirements that we do anticipate, despite we know the hard work that the department's going to do to help people stay on the rolls, but we know it's going to probably going to have an impact on folks losing coverage. So looking at that, not only from the perspective of the folks that lose coverage, but from the providers that are providing that service as well, because with the FQHCs and the community mental health centers, you can't just stop serving somebody because they lose their insurance. And so it's going to have a huge impact, not only on beneficiaries, but on our safety net providers. And I think keeping that as an agenda item so we can keep our finger on the pulse of what's going on with that would be really important.
Yeah, so to summarize that for me, again, it's really staying upstream of the changes, and that dialogue will inform your own internal workflows, but it has a significant impact on our workflows. And, for me, for example, every single week I'm reviewing who's a GA. And my team has to go in and flag them as GA in my system.
Great advantage.
Yeah. And so at least I know that, but I guarantee you every provider isn't doing that, right? Because
No, it's an excellent point. We didn't used to capture that. And now I'm saying we have to figure out a place in our client management system to
Correct.
capture whether you're APT or whether you're GA. So it's a thing.
it is. Yeah. And we're doing the same thing with work requirements. What are the work requirements? They're not all work, but what are the allowable activities. And now we need fields for all of that, and we need to be able to track and monitor so that make sure we have mechanisms that get you the information that you'll need. But of course, I'm not foolish enough to get ahead of you all. So that's why the conversation becomes important, so that we can follow.
Yeah,
Thank you.
I see we have a couple hands raised. Marissa?
Hi, I just want to add to what Holly said. And also she mentioned the FQHCs, and I also want to put the HCBS waivers in there as well, and the DD services, because we're particularly concerned around the change to the retroactive payments, and want to make sure that whatever is put in place at the Medicaid office as far as eligibility is not going to create a situation where people are, somebody mentioned earlier, the providers as well, making sure that basically the system keeps running. So I just want to make sure that that is kept as part of the conversation.
Thank you.
I can't read the other hands. Joe?
Yeah, Joan.
All right.
Hi. Just quick question. What does GA stand for?
Granted advantage.
Thank you.
Thank you for the acronym check. I'm trying to be better about that. So we'll speak more to federal updates later in the agenda too. These will be good questions to keep on our radar.
Let's move on to membership with Kelly, please.
I think that we just have Sam Burgess that we're recommending for membership for New Futures.
I believe Jake Berry is moving into the alternate role.
So do we vote on this?
Yeah.
So we would look for a motion to support that.
So moved.
And a second.
I second.
Thank you very much. Do I need discussion? No? Great, thank you.
Vote all in favor?
All in favor?
Aye.
Aye.
I'm gonna abstain. I haven't seen that. I'm not on the subcommittee. I haven't seen the resume. I have no idea.
Okay.
Abstain.
I don't think we captured enough ayes for the motion to carry. If you are in favor, could you audibly say aye?
Aye.
Aye.
Hi.
Thank you. Any nays? We have one abstention. Do we have others? Hearing none. You got it, Kristen?
Yep.
Thank you.
Yeah, I think that's the process that we've always used. So when we go back to look at the bylaws, if it doesn't make sense, we can address it there.
Okay. All right, let's move into one of our beefier topics for this morning, the MAC and BAC transition and bylaws. Take it away, Olivia.
Thanks. So this has been on our agenda for the last few meetings. I'm just going to take a couple minutes to recap the journey to today, and then we'll dig into the bylaws themselves. So as most members will probably recall, over a year ago now, there was a new federal rule issued pertaining to the Medicaid advisory committees. It required us to establish a beneficiary advisory council, and then also introduced some required changes on the Medicaid advisory committee. And in the intervening year, basically, we've been focused on establishing a BAC recruitment plan, distributing that recruitment plan. And then we've had a BAC subcommittee and an MAC subcommittee on the bylaws, advising on what those should look like. And then we had a meeting with both of the subcommittees together to kind of finalize the drafts of both, and Kristen distributed them. The major changes across both of these sets of bylaws, just to talk them on a high level. One is that we are required to have term limits. So members can't serve consecutive terms. They have to have a set term. This does not change institutional seats. I want to be really clear about that. So we're still allowed to have an institutional seat that, endures, but the individual in that seat has to have a term limit. The department has suggested 4 years as the maximum term a member can serve. We surveyed all the current members of the MAC on their sort of preferences for a term and put some suggested terms together where basically if folks wanted the maximum, they got 4 years, and then some of you suggested a shorter year term. The only difference from that general rule is MCOs have to be represented now on the MAC. So the subcommittee's proposal to address that is to have 1 seat added for an MCO to occupy. It would be a 1-year seat rotating between the 3 MCOs, and we would just go alphabetically, have AmeriHealth fill that seat for the first year and then rotate among the 3. So that kind of covers the membership provisions. The other really big area of change is cadence and frequency of meetings. Because the federal rule requires the BAC to meet before the MAC and have influence on the agenda and focus of the MAC, the department felt what would be sort of administratively possible, and then that was also confirmed by bylaw subcommittee input, to look at a quarterly cadence, where in each quarter, the BAC meets once, the MAC meets after that, and then basically that repeats quarter after quarter. That's a big change from our monthly cadence now, but I think that's what would let us have a good cycle of input coming out of those BAC discussions. And of course, for either BAC or MAC, if we ever wanted to have a special meeting, an additional meeting at the direction of the members, the department would set that up and schedule it. There are other changes. I think those are the 2 biggest ones. So I just wanted to kind of spotlight them. We didn't receive any feedback by email in advance of this meeting, but let me just pause and see, upon reviewing the bylaws, does anyone have questions or items for discussion they want to raise?
So I'll add a comment, if that's okay.
Absolutely.
Right, with the MCO membership, it doesn't preclude MCO attendance or participation. So just like it's an open meeting, people can come to it. Right, that was important.
Yeah,
Yeah, that's a good point. Yep.
This is Bill Keena from AmeriHealth that works for us.
Great. I think Marissa, you're raising your hand.
Yes, sorry.
Oh, that's okay.
I am wondering, I really appreciate the presentations from the department, particularly the data, the DDU. Is there anywhere that we can get that information in between quarterly meetings? Is there a dashboard or some way that we could see some of that information, particularly as we go into such significant change? I worry that with all of these changes, a quarter is a long time for people to fall off of Medicaid or to sort of experience some adverse effects. I'm wondering if there's any way that we could get more frequent updates from the department.
Yeah, Marissa, that's a great point, because something we talked a lot about is, how do we make that shift and use the time well? And one of the things that came up was maybe we should have more of like a distribution of information, and then the actual meeting is time for discussion rather than presenting, all of the information that's happened since the last meeting. So yes, we could definitely still maintain like a monthly report or something like that. And then I think that would help us then come to that quarterly meeting with the time focused on discussion. Does that align with kind of what you're raising?
Yeah, absolutely.
I would just suggest that we contemplate, if that's what we're going to do, you are going to have questions or comments on a monthly basis, so that we have a very specific process and who our questions are going to, so that, well, you don't get the same question 10 times. So think about that.
Other questions, reactions? Okay, well, I'm going to probe a little further by looking at the term specifically, because I just want to make sure everyone is comfortable with the direction we're going there. So let me share my screen for one moment. Just give me a second. So this is, again, if we approve the bylaws and come out of today's discussion moving forward, these are the terms that we'd be establishing. And I'll scroll down. I don't mean to like put a spotlight on anyone, but the highlighted cells are where we didn't really hear back from you on your preferred terms. So we put just a 2-year like default, but we can definitely change these. So following this meeting, I'll distribute this whole roster. And then if folks want to make any final adjustments to their terms, you can absolutely do that. I'll also note, you can always end early, right? These aren't, don't feel locked in if you're unsure about the 4-year term. But that's the default we went to if you indicated you were interested in remaining on for a longer time. Joan, do you have your hand up?
I do. Michael Auerbach is no longer the executive director of the New Hampshire Dental Society.
Yeah,
So
we were trying to get in touch with them to identify who would be in this seat.
You did,
so,
okay.
Yeah.
All right.
We're working on that. Yeah, so that's why that one's just a 2-year for now, but it'll depend on when we identify that person.
I believe Dr. Earl Simpson is interim at this point in time, but you have to confirm that. Yep. Joan, thanks.
My term says 1 year. Last week you told me it was 4 years. I'm not going to be upset if it's 1 year.
No, I think
you're trying to say, Kelly.
At all.
We'll put you as 4.
Oh,
Sorry about that.
sorry.
That was definitely,
I know, we did talk about. You can shift me in 4 as well.
great. Okay, I think you're scroll down. And then one thing I'll just highlight is Kathy, so I'll say a lot of folks in this group, bring their own personal experience, which is part of what makes it a strong forum. On technical terms, we have 2 members who are like consumer members. One, and they've both indicated, Lisa and Kathy, that they're willing to also serve on the BAC because we are required to have overlapping members between BAC and MAC. So I just made a note of that here too. And then Dean, I'll update you at 4 and take off the highlight. I think someone else has their hand up.
Joan, do you have another question?
Oh, no, sorry. Let me raise my hand. Yeah.
Okay.
So do you have any concerns, Olivia? A lot of people stepped up and said 4 years, but I know you wanted to sort of stagger so we didn't have, 75% of the committee rolling off at the same time. So now that you have everybody's preference, does it make sense for you to go in and like randomly tinker to make sure you don't have everybody terming 4 years from now?
That's a good idea. I mean, one thing we could do is just stagger at least a little bit within months, so that you're still getting a 4-year, but maybe your start time is a little bit different. So if folks are comfortable with that, we'll do that tinkering.
Yeah, you can change the beginning of the term.
The effective month. Yeah, that's a good idea.
Okay, good. And thank you to everybody who responded, and especially if you were like, yeah, I'm down for 4 years.
Yeah, thank you. We were pleased to see that there was a lot of interest in being a longer tenured member. I guess I just want to pause again. Any other remarks or observations on the bylaws? Go ahead, Dee.
I thought the regulation was requiring a higher percentage of MAC members overlapping with BAC than 2.
It's the initial requirement is 10% overlap. And so the BAC we have almost like completed. I do think we'll have 10% at the time. So yeah, there will be a couple other people added to that list we just saw from the BAC to achieve that 10% overlap the initial year. So that's a good point. There will be additional members coming from the BAC once we kind of confirm who in that new group is interested in doing the
In
double.
serving on the MAC.
Yeah, the double.
And thank you to both Lisa and Kathy for taking that on.
Yes, thank you, Lisa and Kathy. Yeah, and again, hopefully the quarterly cadence makes that a little bit more feasible for those who are on both forums. I felt like there was one other thing I wanted to call out. Now it escapes me. Oh, I guess I was just going to mention, so we do have the August meeting scheduled. So that would be, you know, if we voted and there were no changes to the bylaws as drafted. Joan, I think you're fine. Could you mute yourself?
Yeah, thanks.
So we would have that August meeting, but then after that August meeting, we would move into that quarterly cadence. So I just wanted to call that out if there was anything folks wanted to take back in August or.
When is the first BAC?
That I'm working on scheduling. I've got almost everyone's availability input, but we don't have it final yet. But I would be looking for that to happen in like September or late August. And so then that would happen before later in the quarter, the BAC or the MAC. Okay, last call for feedback. Okay, Lisa.
Oh, sorry, this just came in, Sam Fergus just emailed me. He wanted I'd elect for a 4-year term.
Great, thank you, Sam. Yeah, sorry to.
Okay.
I'm ready.
Okay.
For some reason I can't mute her. I think it's because I'm not a host. Thanks, Kristen.
Oh.
Kathy, is there anything you want to raise?
Oh.
Yes, I'm sorry, I was having trouble with my computer.
No, it's okay.
Really big trouble.
We can hear you now.
Do you have a
Okay.
question or?
No,
No, okay.
I just got here.
Yeah.
Okay. Well, I want to thank everyone in the subcommittees for all the time they spent and offline work reviewing and editing these bylaws. Really appreciate it. I think if there's nothing else, then we can probably call a vote to approve
The bylaws?
the bylaws.
Mhm.
Sure.
Oh, hold on, Joan? Joan, you have a question?
I think that might be a
I
mistake.
got on mute now. Sorry.
That's okay.
Yes, I'm gonna put 2 years on and give me more time to work with someone to take over.
Sure. We'll update that now.
Thanks.
All right. So we'd like to call a motion to approve the new bylaws, please.
So moved.
Thank you, Kelly. Do we have a second?
Second.
I'll second.
I think we have to
That's
give
great.
PD in the room, but thank you everybody for jumping in on that. Any discussion? Okay, all in favor?
Aye.
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 Any,
Aye.
we have
Aye.
any nays? Any abstentions? All right, the ayes have it.
All right, so I'll push out what I screen shared just so folks can have a final look at the terms and the effective dates. And we'll distribute the finalized bylaws, and then stay tuned for there'll probably be some communication for just setting up those quarterly meetings and making sure that the schedules and times work for everyone. And then the last thing I just want to highlight for next steps is we'll need to in August kick off our process on chair and vice chair since we're transitioning to that new forum. So thank you all very much, and I'll hand it back to you, Lisa.
All right. Thank you. All right, so we're gonna move into our discussion of state legislative updates. And I know we've tagged Rob with this, but I think you could tell from the commentary at the top of the hour and just from the pings I was getting before the meeting, we're really hoping to make this more of a this passed, that didn't pass conversation, more of a like, here's what we're thinking. You know, so if I could just use an example, I raised several months ago when the idea of premiums was under discussion that, you know, in the Wayback Machine, when we suspended premiums for CHIP, it was because it was a clear barrier to enrollment and it cost more to do than we could collect. And, you know, so my question was like, what's changed over this period of time, if anything? Or, you know, is it going to be another one of those things where we're going to spend more than we collect and we just have to like bite the bullet, or what? So again, I'm hoping that we can have more of a, hey, here are the things that we're wrestling with, here are the things on our mind as we think about these changes, because I feel like once we got to the June meeting, we had a pretty good sense of what was passing and what had long odds of passing. I mean, maybe there's a couple of things that came in under the wire that are worth mentioning, but my sense from the committee members is that there's a lot of interest in how we're going to execute, how you guys are going to execute some of these big changes and the timelines attached.
Yeah, I mean, I don't know if we have a lot of answers to those for today. You know, it's the budget just passed, you know, not too long ago. There's still a lot we're sorting out in terms of how a lot's going to work out. There's a lot of overlap with federal law, as I think David's going to speak about in a few minutes as well, especially when it comes to the work requirements, where we do have competing law with both state and federal, where we have strict requirements in the federal law and we have strict requirements in the state law, and how do those overlap and how do those interplay? So we have a lot to wrestle with in terms of how it's going to work. So I don't know if we have a lot of real solid and firm answers for you today. David, do you have anything to add to that?
I think on the premium front, we have a meeting this week with DAS to talk about one of the, they have an ability to accept payments from people. And so we would leverage that, potentially that software solution to accept the premiums. The amount of the premiums were hard coded into HB2. We have a technical assistance request out to CMS because there's sort of two issues we're working through and we need CMS guidance on. And one is to create the hardship criteria that's in HB2 that I think we've also discussed at this meeting, where someone would be exempted or accepted from premiums so that it doesn't impact, say, their inactive treatment for cancer or something like that. We don't want premiums to be a barrier to treatment. And then the second piece to that is how the continuous coverage requirement of children, so kids get 12 months continuous coverage under federal law, and how the non-payment of premiums would interact with that coverage requirement. And I think the coverage requirement, failure to pay premiums, I don't think is a permissible reason to disenroll a child with the coverage requirement. So it's more specifically around what happens at redetermination for that household. And from a timeline perspective for the children's premiums, we're looking at early 2026.
Is that the kind of detail that's sort of helpful to start sharing in this forum? Are there other considerations you're?
Yeah, it's kind of like a beyond the bill conversation, you know?
Yeah, because I guess what occurs to me is that from the moment one of these things hit an LSR, you guys were issue spotting, right? And trying to figure out what are the non-negotiables that you have to alert a legislator to and how they respond to that. And then what are you left with at the end, and how, you know, how do you try to have fidelity to the intent of that piece of legislation without doing harm. I mean, I think that's, I mean, I'm trying to speak for others, but you should speak up. I think that's sort of at the heart of the curiosity. I don't know if others want to harmonize on that point.
Yeah, I think needless to say, the next meetings are definitely going to have a section committed to these new changes that are impacting the program. And I think just this iterative feedback is great to just make sure the information we're bringing back is responsive. And
Yeah, I mean, we're still digesting a lot of it. At least I am. I'm still trying to synthesize a lot of the federal changes and the state changes and how it's all going to work in the end. We still have the Senate bill hanging out there that did not, that was held up in the House committee for work requirements. The House wanted to make some changes to it as well. There's a committee out there that was passed through HB2 about studying long-term care and Medicaid care management sense too, which is going to be seen some action as well. So there's a lot to think about in between now and, I guess, now in the next legislative session. So we'll definitely be looking at it and developing plans. We have some state plan amendments to prepare. We have some things to think about. So we can, we're definitely prepared to continue to speak about it at the upcoming session and stuff. But yeah, I haven't had much of a chance to really speak with David or Henry about what our plans are or anything like that.
When you think about things like the premiums effective early 2026, it wouldn't be constructive for me to find out what I have to operationalize in December. It wouldn't be any more constructive than you to find out that you have something in December to stand up for January. So thinking about it, I'm really sorry how my mind works like this, but like in Gantt chart.
Yeah.
And being able to glide path into, and maybe it can't be done. I mean, I certainly know that, the best of intentions might be to get information, be ready for October, but it's just not realistic because 90 days, not much gets done in 90 days, right? We have 15 different places that have to look at these things and sign up on them and get downtown and everything that has to happen. But always understanding, like, we need lead time to be able to engage families. 30 days doesn't do it. 30 days might do it for 80% of my families, but those are the families I'm not worried about. It's the 20% of those families that it's going to impact, and it's going to, in very significant ways. So the conversation, like I said, beyond the bill is really important.
And, I would just flag too, if we're talking about premiums, how does that play into disenrollment from MCO, and then when you pay, catch up, like all of that, copay changes. It's going to be a lot, not just for individual recipients, but obviously, that's the tip of the spear. But for all of us agencies that are out there trying to support people in this, we want you to be successful in what you have to do, but we can't be successful if we're not given good information in a timely way. And I think, one of the downsides of moving to a quarterly cadence for these meetings is that we don't get as many bites at the apple to have a constructive conversation about, hey, did you consider this angle versus that angle? So I don't know if there's going to be a process to sort of keep conversations going.
Right. I think some of these changes could be good candidates for those one-off extra meetings that we might have, where if we're like on the eve of work requirements going into effect, or whether that eve is 30 days, 90 days, to your point, Kelly, but But that could be a good candidate, right, for the MAC to say, we'd like a special meeting on this, because it's a big change and it's coming up. So we can definitely keep that on the radar too.
I mean, a lot of
even if
times,
you're,
oh,
sorry,
sorry.
Kelly. But even if you're thinking about like public forums, like things like that, like let us know. Either, you know, we can show up or we can try to bring our people or we can offer you a space or all of that kind of, all of those parts of what an implementation entails.
And it's not unusual for bills to pass effective July 1st. And as long as you're all thinking and understanding what that downstream impact is, I have confidence that can say, look, we're always going to be advocating for things, especially around these bills, the big bill, that it requires 90-day lead time for, you know, your beneficiaries. So just something like that.
I mean, I think it's really critical what you're both mentioning is just consistent and clear communication. We both know there's sometimes we can't, we don't have the information or we can't move
Exactly.
quickly enough, but as while we move, we need to communicate. And I would say that it needs to be bi-directional, right? That we have feedback and we're open and and the team, as much feedback as possible. I mean, there's so much going on. Change the period. We're trying to figure it out as well. And there's some, I mean, some of it requires law amendments, right? State plan amendments with CMS, and some of the federal and the local are in conflict, or so
Something we're working for? What requires it?
Do we want to just walk through that?
Yeah, do you have it?
Yeah, I can share it. 1 second. Just give me a moment.
There's a hand up. Marissa, is there any number?
Marissa, do you have a question or?
Yeah, it was a little hard to hear some of the conversation a few minutes ago, but I'm wondering if there is any anticipation of regular communication from the Medicaid department or Medicaid office regarding what changes are going on, because I think about what Kelly was saying, that not only are we asking agencies to make operational changes, but they have to make operational changes in order to push down information to families. So it's not only the beneficiaries, but I mean, it's the whole system. So where is the best place that people can go for information so that they can start operationalizing some of these changes?
Yep. So that's a good question. I'm going to share, we put together sort of just a high level, you know, again, what we know today, picture of some of the changes coming. And then I think that question of how do we kind of stay in the loop on all of this is good to consider for the future MAC meetings, and to your point, maybe off of the meetings as well. I know the text is really small, so I'm just going to say sorry about that.
I think everyone at the department agrees, you know, we're open to honest and transparent communication and about the changes, and whether that's through forums like this, other community stakeholder groups, keeping the website updated with changes that are coming. I think there's probably a lot of components. I don't think we have all the answers right now, but we're certainly committed to, you know, being transparent about what's coming and how it's going to work to the extent we can.
You want me to speak over this, or do you?
If you want to.
Okay. Yeah, well, Dave will check me if I'm getting any of these wrong. But I think this is just a really basic diagram of by year, what are some of the new policies effective. Purple is the federal HR 1, formerly referred to as the One Big Beautiful Bill Act. And teal is the New Hampshire state budget, HB 2. Again, for folks in the room, sorry, it's probably easier to see on your own screen. But you know, we're in July 2025. Federally, there's a few things that go into effect immediately. One is concerning state-directed payments, which won't have an immediate effect on us, but is something we'll need to plan for down the The thing in pink is that there's a 1-year prohibition on Medicaid reimbursement to Planned Parenthood. This is currently under a court order.
A restraining order, 14-day restraining order.
Yeah, so we can't really speak to yet how this will go into effect until that concludes. And teal is the pharmacy copays. So under HB2, pharmacy copays increased from $1 to $4. Again, as we've shared in prior meetings, same exclusions, same excluded populations, excluded therapies and drugs. But we are currently working on the operational plan, looking like maybe August or September would be when that goes into effect. And once that is further defined, we'll certainly be sharing it with the MAC and broader provider community as well.
So, I'm sorry.
Yeah.
I just want to make sure I heard you correctly. The actual implementation of the higher copays goes into effect in September?
It's not certain yet. We're working right now on what the effective date will be, but we think it could be September.
Okay, that's like in a half an hour.
Yeah, it's very soon.
Okay.
The budget is based on that change effective July 1st. Of course, that's not possible. So we're kind of working on what's the feasible operational path.
Herein lies my example.
Yeah, it's a great example, Kelly.
Well, I mean, I just think about like the notice requirements. Like, how do you do that?
We'll do them
It's July,
soon. Yeah.
whatever it is today, 14th.
Yep. Yeah, there's 30-day noticing requirements. So we have that in the works now. And then at the end of 2025.
Just one.
Yeah, go ahead.
You mentioned that with CHIP, the non-payment wouldn't disqualify somebody for getting care.
It's two
Or
different things,
reimbursement.
Premiums, different than copays. So,
Okay, I guess I'm just wondering,
but
if an
kids are
adult-
exempt from the pharmacy copays.
Okay. If an adult isn't able to pay their premium increased premium, and then they arrive, and is that gonna be enough for them to cover it? And then what happens if they arrive in the ER?
So there are separate rules for kids premiums and adult premiums. The adult premiums will require a waiver from CMS, whereas the children's premiums we can do through a state plan amendment, which is, for lack of a better word, a simpler process. Part of what's in HB2 for the adult premiums is similar. The department has to create some hardship criteria, which would be part of the waiver discussion we have with CMS. And we don't quite know what that hardship criteria would be. The population is about 10% right now of the Granite Advantage population that would be subject to premiums. We think that that's just a point in time estimate, but the number of people at or above 100% of the federal poverty limit. But assuming someone didn't pay premiums, they could be potentially disenrolled. And if they didn't have Medicaid coverage and they showed up DED, there wouldn't be Medicaid reimbursement for that. I think some of the pieces we need to talk through with CMS are prior non-payment of premiums is not necessarily, that's not a condition of eligibility to reapply for Medicaid. And so how does that process work?
So 10%, that's like
Approximately.
5,000 people.
So maybe it's 20%, sorry. It was around 12,000 people in the Granite Advantage population. And there's about 8,600 kids, so sorry, 10% for the kids, 20% for the Granite Advantage.
And will MAC have a chance to review that waiver application?
Yeah, all waivers also go through a public comment period too, so.
Yeah, you'll see.
Along with the state plan amendment for the children's premiums.
And I can't read that chart, but
Yeah.
whereabouts is that on that chart?
Yeah, so the second bar is 2026, right? So each bar is a year.
Yep.
5, 6, 7. So in January, at the beginning of 26, we have the legislation states that we'll submit the state plan amendment for CHIP premiums. And then July is the submit waiver and state plan amendment for Granite Advantage premiums. But to Kelly's point, this is what we're looking at here is just effective dates. So of course, there's going to be operational milestones, external communications, runways that need to happen before these dates. this is just purely what, each piece of legislation says
And
for effective.
one more piece on the granted advantage premiums, it conflicts with what was passed in HR1, which requires states to implement cost sharing on the Medicaid expansion population and not premiums. So we need to have some discussion with CMS around what's permissible there, whether we could do premiums and not cost sharing, or would be required to do cost sharing and not premiums.
Kathy, I see your hands raised.
Yeah, it is. I'm looking at this chart, and I'm sorry for being so basic, but for one thing, I really have a hard time understanding what all this stuff means. I know some stuff that's supposed to happen because of that big beautiful bill, but I don't understand, like, one thing, I don't understand all these acronyms, and I get that the green is New Hampshire, and I'm getting really basic, I know, but okay, let's start into 2025. That pink part, what the heck does that mean? I don't know what that means.
Yeah, the pink I highlighted in pink because it's under a court order, just to indicate that it's in a different state than the other things because of that. What we're working on, Kathy, but we just don't have it ready today, is like more slides after this one that take each of these bullets and explain, like, what is this? What's the effect to providers? What's the effect to consumers and members, whatever term you like to use?
Yeah,
and what are kind of the implementation things that need to happen. We just don't have all of it ready to present to you guys today, but I think that what I'm hearing is that kind of information is really important for us to pull together and share. Because you're right, these are like 5 words on what's going to be like hours and hours of work and preparation.
Right, and like I have a really hard time with acronyms and stuff, and I have no idea what you're talking about. I mean, I know that there's gonna be bigger copays, for example, and I know it's gonna affect me somehow, but I don't really get all of it. I don't mean to be a problem because you guys all seem like you know what's going on, but
I promise you're not the only one who doesn't know what some of these things are. A lot of these things I was asking people about 2 days ago to put them on the slide. So
okay.
You're definitely not alone. And you're right, we have a lot of acronyms on here that we should spell out. And that's something we could do like immediately when we send this, share it the next time, is make sure all acronyms are spelled out.
Right, I mean, even, because I think what I hear Kathy saying is, like, some of us know just because we know that kids are exempt from that, or, disabled adults are exempt from this, right? But
yeah,
I think we need to be a little bit clearer, because I heard Kathy say, I'm gonna be impacted by this, and I'm thinking, I don't think you are, Kathy, right? So, like,
yeah, we need to start putting together those details of who's impacted and how, and what do each of these things really mean in terms of.
And always gonna help people understand how they're gonna be impacted and why they should, let people know how they feel, and should they let people know how they feel, and if I mean, is it gonna do any good, or is this set in stone? Should people call their representatives, or or write letters, or whatever? I mean, is this, whatever this is this done, so to speak?
Yeah.
And can any of this be reversed when the big beautiful bill isn't the thing? But I mean, when Trump is gone, I mean, can this, I mean, I don't mean to say it like that, I'm sorry, it's just like, you know, this is year, some of this stuff is like a few years down the road, and can any of this change, or is it done, and we just have to deal? That's what I wanna know.
Yeah, that's a great question. The HR 1, Big Beautiful Bill, it is law now. And same with HB 2, it's law.
Could it change? Oh, yeah.
Right,
Yeah.
exactly. That's where I'm gonna
Yeah.
rely
Oh,
on
yeah.
Rob and Dave is like,
Just like tariffs.
Yeah, oh, yeah.
those two pieces of legislation are done. And so everything on the slide is indicated by that. But like the details of how it happens, some of that still needs to be finalized. And you're right, like the years extend into what could be a different administration. Is there anything either of you want to add just on thinking about like when something is done?
Well, and there could be litigation.
Oh, yeah, yeah.
Right, so Kathy, I think to your question, you know, at this point, the only way to undo any of these policies is if there's some creative litigation that has stopped enforcement of any of these policies, or we elect people who have a different view of these policies and want to undo them. But those are sort of the only two paths to undo what you see on the screen this morning.
Yeah, okay, that was my question.
Those were great
Sorry
questions.
if it was naive, but.
No, please, no apologies. Those will be really helpful for refining how we share information going forward. Okay, Sam, do you have your hand up?
Hey, yeah, thank you. Good morning. I had a quick question. I'm not sure who was just speaking on this. It was David or Rob. I know you were mentioned reconciling differences in cost sharing between federal and state law. I was curious about the 1115 waiver that was part of the work requirement law on the state level. Do we have any idea? Have you heard word from CMS if there's going to potentially be a preemption issue there, if they're going to treat the work requirement provisions of the federal bill as a floor that we can move up for? Because I know our state bill requires 100 hours a month relative to the 80 on the federal level. So I'm just kind of wondering what we've heard, if anything, regarding work requirements and reconciling the differences between our law and the federal law.
Thanks, Sam. We're still working through some of that. I know there are certain aspects of what was in HR 1 for work requirements that CMS doesn't have any authority to waive. And so, like in our prior waiver, or New Hampshire's prior waiver for work requirements, if the exceptions for an individual to need to meet the work requirement doesn't align with what's in HR 1, CMS has no authority to approve additional exceptions or exemptions. I think some pieces of it, like having to verify the work requirement more regularly than what's in the federal legislation, is a floor and not a requirement, but would take a waiver to do. I don't know about the 80 versus 100 hours, but I could see CMS thinking about it similarly. But I think we have also heard from CMS that they're going to work to create a sort of like a template work requirements waiver state plan that states could use for the authority piece. So I think we just still need to work through the nuances and differences between, you know, what's currently in New Hampshire state law and what was passed at the federal level, and where there could be areas to change some things.
So for a future meeting, can we get sort of a little more detail on what those things are?
Yeah.
Thank you.
Thank you.
Dave?
Yeah, something that Kathy brought up. I'm curious about how you guys are thinking at accessibility in both like plain language, in both like the MAC information, so like a table like this, spelling out acronyms and things like that. Especially as we bring on the BAC, which is more consumer side, less professional. But also as you kind of roll out this information, it sounds like you're working on the copay stuff right now. How are you ensuring that the language that you're using is plain language, that the forms are going to be accessible on multiple formats? How do you, is this on your minds? I'm sure it's on your minds, but like, this is something like we really need to work on.
Yeah, I mean, I think, good.
I agree.
Yeah, I think that's something, especially for like the premiums and work requirements, we should add in as like another point of discussion with these groups, because the copays, like, it's, you know, member handbooks and notices will be affected with that information. Those things are subject to accessibility requirements or MCO contracts in terms of like reading level and form and format. That's like the very dry answer to your question. And I think it goes deeper than that of like, how do you make all of this information more accessible and digestible? But it is on our minds for getting that noticing out. I think it's a bigger question. How do we address it for just making folks aware of all these program changes?
I have a suggestion. Can I make a suggestion? Chris Pappas, when you look on his website, he always has like videos explaining what he did for the week. So you can put this information on a video. Like, you know, so people can go to the website and not have to read it and understand it. They can, but if they can't, then they can just like watch a video and then someone's art on YouTube or something, you know, and someone's explaining it, you know, and they're not using 5 million acronyms, and they're talking in plain language, because so many people don't understand the written word, and it's easier to watch a video. That's what I would do.
That's a good idea.
Yeah, the more formats we can get it out in, the better. Just remembering that with video, subtitles, ASL, and transcription all be available.
all
videos
that.
put out by the department.
And give examples of like, so like if you know, like if you gave an example of what it means to have like a question or whatever, you know, and use whatever format you can to get the information across, you know, and I don't know, because this is very confusing to look at this.
Yeah, that's a great suggestion that we can take back, is whether video can be used for some of this.
Yeah, I think we have some videos for the online.
My background is in special ed, so that's where I get them.
We appreciate it, Kathy.
I anticipate you'll get great feedback from the BAC.
Yeah, definitely. I think this will probably be a focus of a early meeting, that group.
And with this, I mean, with this slide, we really just want to show that the timeline and all the different things that impact Medicaid through the federal legislation, the state budget, but not necessarily are ready to dive into the discrete details of each bullet there. I mean, some of this stuff is only 10 years old.
Any other questions about?
Marissa on the chat said, could this chart be emailed, shared by email?
Yeah, it sounds like we'll tinker with the make it less acronym heavy and a couple other changes I heard in this conversation.
What you could do in order to make it so the chart keeps on one page is add a second page with an acronym list.
Yeah. Oh, that's a good idea. Guide.
We have a 180-page acronym list at the department.
But yeah, I think, this is like a really early cut of information, and this feedback on what would be useful going forward is great. Holly, did you have a question?
I only had a question, and then if we're gonna talk more about the budget, I can hold off on it, but I just had another question, regarding, the back of the budget cut, because I think that's something else that we're gonna need to hear about going forward, given the fact that, a lot of the programming that could be impacted is, programming that Medicaid recipients, are receiving. And if the extra funding is not provided to those programs, they could be cut. And so, again, if we're not moving on from the budget, I mean, if we're still talking about the Medicaid issues, then this can be put on pause. But it's something that I would like the department to address under the legislative. And I know that Rob doesn't have any answers now, but just, teeing that up because it is a huge concern for NAMI right now.
Yeah, we can certainly keep that on the agenda to talk about at a future meeting.
Joan?
Hold on, I had to unmute. Yes, on January 2026, when you're looking at the report on premiums and adult dental, what are you looking for? Is that you looking to reach certain benchmarks in order to continue funding? What would be the goal of that?
I can share the legislative language as a follow-up, Joan. There's some language in the bill about the information that the commissioner includes in a report to legislature. I just don't have it at my fingertips.
Okay. Is that the goal of the report, is to evaluate what was happening and what the projected costs will be?
For the dental report, the goal is to speak to the impact of the program so far, but in terms of cost and clinical value. For the other one, I don't know. I have to go back to the legislative text.
Okay, thank you very much. I appreciate that.
In the chat, Marissa Berg wrote, referencing the page number or section of HR1 for each federal item would be also helpful to understand the bigger picture.
No promises there, but it's a good idea.
Then Vanessa Blaze said, is it possible to slow down the process by requesting New Hampshire apply for a waiver to delay the implementation guidelines due to time resource constraints?
Good question.
There is a section of HB1 that does, or sorry, HR1 that does allow states to ask for additional implementation time with work requirements. It can't be extended out past 2028. But there's also an HB2 provision that requires New Hampshire to file for an 1115 waiver to implement work requirements. So I don't know if New Hampshire would be electing that option.
Just checking the chat. Okay. Any other questions? Comments? I just want to acknowledge, I know it's a really chaotic time, like with all of the information coming out every day. I think we are starting to be at a point where we can, gather everything and communicate it out, which was, kind of our very first step today of doing that. And I just really appreciate everyone's candid feedback on how do we make that information more usable, more valuable to all the different groups that this committee represents. So thank you, and keep it coming.
Great.
That sort of concludes our conversation about the state and federal legislative changes. Let's go quickly to enrollment and eligibility.
The monthly eligibility update for the redeterminations that were due in June. I also have some slides in here that help explain some of the CMS flexibilities that expired at the end of June that we talked about previously at MAC meetings, but we wanted to give everybody a little bit of a refresher there. So as part of the public health emergency and the unwind, there were certain state flexibilities CMS let states use to increase the passive renewal rate for financial eligibility. These flexibilities expired at the end of June. They were mostly directed at streamlining the way in which states can verify income by using external data when they either have something in the case file and the external data doesn't contradict it, or there's something in the case file and there is no available external data for it. With the expiration of those authorities, the takeaway for beneficiaries is that more people are going to need to submit a renewal form to verify their income at redetermination, which means more people will be getting a notice from the department that says, please provide verification of your income. It'll have the due date in there, and they would need to provide that verification to be able to renew their eligibility. If their verification isn't provided, the individual would close for failure to provide, and then everyone has a 90-day reconsideration period. So this is just an example timeline, assuming your redetermination was due in July. So the REDI form would be due in the month of July. Previously, there were some cases of if the person was enrolled in a waiver, where if the REDI form was not submitted by the REDI date, they were given kept open and given additional time to complete it. That expired as well on June 30th. So they would have a 90-day reconsideration period. So in this example, the case would close in July, that's the middle bubble. And then on the right-hand side, you have the 90-day reconsideration period. So August, September, and October. And what happens in the reconsideration period is you only have to provide that one piece of whatever is missing from the redetermination. So in this example, it would be verifying the income. And so if they provide verification of income, they would reopen just by providing that and not completing a complete new application.
That's expired?
No, that's still in effect. What's expired was the for waiver populations, they were given an extra 60 days where they remained open. So when you're in your reconsideration period, your Medicaid eligibility is closed. But within the reconsideration period, you only have to provide what's missing from your redetermination. And then there's retroactive coverage.
Without even, I might get the word wrong, but that 90-day reconsideration that's triggered by uploading my missing verification. I'm losing my train of thought. Doesn't require a simple application.
Right, you would just have to provide, you could provide a simple application, you could provide a complete application, or you could just provide your income verification.
Okay, that's very inconsistent in practice, just saying, but, okay, thank you.
So as part of this, we did institute what we're calling the Pink Letter Campaign, and this started in April of 2025. And this is for the clients that are due for a redetermination, to just let them know that, there have been these changes. Approximately 60 days before your redetermination month, you're going to get this pink letter. if the person is elected to go green, they'll see it in their New Hampshire Easy account. And that it's really just to put individuals on notice that it's less like, these changes have occurred, and to be on the lookout for their Medicaid renewal form. And it's really important to return the renewal form and the required documentation to renew your Medicaid eligibility and remain open without a gap in coverage. And this campaign will run through, right now it's scheduled to run through March of 26. It'll go out on a monthly basis. And we're still doing the yellow and blue letters. So yellow alerts individuals about the need to complete their Medicaid redetermination approximately 30 days before the redetermination month. And then the blue is the Blue to Renew campaign, where the blue letters are for individuals who are due for a Medicaid redetermination but have not yet submitted one of their required verifications yet. So they've gotten the renewal form, we're still missing some information. We send an additional blue letter to that individual or household, asking for them to submit their redetermination paperwork. We also have emails and text message nudges too that go along with this.
This seems like a silly question because I'm in and out of there so often, but are the letters color coded in easy?
I'm told they highlight them in yellow, blue, or pink.
Perfect, thank you.
And this is just a summary of what all the different colors mean. So pink is like it's almost time for you to do your redetermination. Yellow is a notice to renew in the next 30 days. And blue is, we're still missing documents, you're overdue for your redetermination. And then there's the standard 10-day advance notice that goes out prior to someone being disenrolled for not completing their redetermination. So this is just a summary of the timeline of when these notices go out. So pink goes out approximately 2 months prior to the redetermination date. Yellow goes out on the first Wednesday of the month prior to the redetermination. Blue goes out on the 5th day of the redetermination month. And then the advance notice period goes out 10 days prior to the end of the redetermination month. So if we're using the July example, the pink letter went out end of April, early May. That was then followed up with their yellow notice in May. And then in June, someone would have gotten the blue notice. And then at the end of June, if they hadn't provided what was missing, they would get their 10 days prior to the end of June, they would have gotten this advance notice.
May I ask clarifying, because my mind did not hear what you were saying. That all applies to a July readee that you just said? Because it sounds like a June readee. Because I would expect it in July readee. I'm sorry to ask this question. People pay no attention to me, it's gonna confuse you. That the first Wednesday of June is when that yellow notice would have been triggered.
This one, let me double check, but I think this goes out for your, yeah, you're right. This would go out, the yellow one would go out June, early June. Yeah.
I love this. I love this for my staff and my team.
To that point though, maybe we'll put like actual month dates in here rather than 2 months, the month. It's easier to interpret that way. All right, now to our more regularly slide updates with the Medicaid enrollment. This is a point in time enrollment for July 1. The Granite Advantage population was at just above 58,000. The total population was 182,000, which is a little lower than we've seen. It's been around 185 back in January, and then 184. And here you can see the change in prior months, and this is just measuring the prior year, so July 1 of 24 through July 1 of 25.
When's the dip? I mean, what, is it a specific day? Is it a month? What moment in time is it?
First of the month.
Literally the first calendar day of the month?
Yes.
So I'm just gonna shout out again that, you know, all my kids who were in that category of moving from CHIP to the new T eligibility category had no eligibility on the first. All my 271s, all my verifications from MMIS and EASY had them uninsured until the second. So I don't know if that's gonna influence that, if it was on the first or not, but think about it.
I think, because this pulls from, I can take back and ask
It was
Andrew,
the
but
nights too. I mean, it's easy. I drank it in nights. It was in New Hampshire easy. But I had a lot of people, well, you know,
That was just most recently, right? That's not
July.
recurring.
Yes, it just July 1st, all those kids that were transitioning
Yeah.
were closed in CHIP. And then they were reopened in their new category. But it feels like maybe in Heights, they were voted to be opened for the first, but that update went through the night of the first.
Right.
Meaning if you were looking or running reports or looking at data on the first, you weren't gonna see it till the second.
Yeah, I think that was a one-time.
It is.
Yeah.
Yeah. But it might, I wonder if it's gonna influence that. I'll be interested to see your next month or your next quarter slide there.
and just for everyone else, what Kelly's talking about is the state had a finding from CMS for kids that were in the CHIP category that had other insurance. And one of the eligibility criteria is to be in CHIP is that you don't have other insurance. But there is another optional eligibility group that the state was able to get permission from CMS to use to transfer, to keep these kids within Medicaid. And so we had to transfer them from the CHIP category to this new optional eligibility group.
Because it only applied to CHIP.
Yeah. And it ties back to how much federal funds are tied to the eligibility categories. The CHIP kids without other insurance get a higher federal match of 65%. The ones with other insurance get a 50% federal match. So it's aligning our Medicaid federal match dollars.
Thank you.
And this is a similar look on a longer time frame, but start of the month enrollment from November 23 through July 1 of 25. This is the dashboard for June readies for the total population. So there were 10,672 cases due for redetermination, 1,289 closures, 9,100 completed the redetermination. Of the renewals, the majority were done passively, just over 8,100. And the largest category of closures were the failed to read category. And the failed to read category, that tracks individuals that did not submit, say, their any required documents to renew. So if we weren't able to passively renew them due to say income, this is where these people would show up for failure to verify income.
But it's not the failure to provide category? They're not in there. They're separate.
Correct.
Then I can't say that. I'm having a long
And then
thing in my
separately,
head while you're having this.
the individuals that show up in income are people that provided their documentation but are the income limit and therefore did not return.
Thank you.
And so this is a subset of that total population that just looks at kids. And so there were 3,873 children up for redetermination. The large majority of them completed the redetermination, remained open at 3,262, and there were 456 closures. This is the waiver population. So there were 905 individuals in waiver that were up for a financial redetermination. 834 completed the redetermination, remained open, 64 closed. And this is just the CFI population. There were 217 individuals in CFI up for a June redetermination. 198 completed the redetermination, 17 closures, 9 for not meeting program requirements, 4 for income, 3 for failed to read, and 1 for other. And this is the nursing facility dashboard. So there were 294 individuals in a nursing facility up for redetermination, 257 completed redetermination, and 34 closed. This is our CMS reporting for the month of June. You can see the retained rate in this peach color is 87.6%, which is what it's been at for quite a while. And this is the updated slide for the ex parte rate. So you can see we were in the mid 70s with the expiration of the federal authorities. We're back down to 25% ex parte in July and 29% ex parte in August. So it looks much more similar to prior to the unwind of what the ex parte rate was. And this is the impact, what we were talking about at the first part of the presentation, with the expiration of those flexibilities from CMS. More individuals will have to complete the renewal form and provide it back to the department to redetermine their eligibility. And most of these are around income verification. Here I'll pass it to Vern to give an update on the call campaign.
Hello, everybody. So the call campaign, June calls for May closures. 893 individuals on the call list for the managed care organizations. Messages left for about 47%. 277 were reached, about 31% of the individuals. For the ones that the MCOs were able to engage with, that 31%, we had 25% had done their redetermination, and that number has stayed pretty consistent over the last few months. Looking at we have seen an increase in those who are aware and actively engaged in working on their redetermination. 3 months ago, it was 36%. It increased the previous, the month before now to 46, and this last month we were actually 50%. Said that they knew that they needed to do their redetermination and were working on it. Individuals that they reached that indicated they had new insurance, 34, 17 of those were children. We had a new category this month. We started what we call a warm transfer, asking the MCOs to actually, when they have that person on the phone and there's a question about whether or not they were going to be qualifying for New Hampshire Medicaid, to actually stay on the line with that person and transfer them to the navigators so that they could talk with the navigators. And if it turned out they were no longer eligible for New Hampshire Medicaid for income requirements or anything like that, they could actually work with them to determine if they qualify for coverage on. So that was something that we did a soft launch. That's going to be continued on in our ongoing call campaigns. But about 4% of those individuals actually stayed on the line, and there was a warm transfer so that instead of just getting somebody on the line, the person from the MCO was able to say, this is who's on the line, this is what they're looking at, and give some of that information. Much better than just a cold dump when someone gets on the line and who are you? So seeing some improvement with that. We'll go ahead and go to the next slide. So for the Medicaid medical unit, the 90 of the most acute individuals who failed to renew in April and still had not done their renewal at the time that we were doing the outreach, messages had been left by the MCOs. The Medicaid team was able to reach 29 of those individuals. And we found that 16 had, by the time that we had called, had done their redetermination open. 2 were aware that they needed to do their redetermination and were actively working on it. So these would have been individuals within that 90-day period where they're allowed to fill in the information that was missing. No one was unaware of the need for redetermination, so there was no surprises for the ones that we reached. No one had moved out of state, and we found an additional 9 individuals who had insurance coverage now. All 9 of those were children. If anybody has any, what's that?
So thanks, Mary.
Oh, sure.
That's the end of the slides, but we're happy to take any questions.
I'm just curious, when you're doing calls for beneficiaries who are under guardianship, who do you call?
The guardian. So whoever's listed as the head of the household. So if it's a child that has a guardian, we would call.
I'm talking about adults under guardianship.
You may not know if what's listed as a guardian or not.
Yeah, it could be that there is an individual listed as a guardian, but they would be the case head. So we would be calling whoever is indicated in New Hampshire Easy. So in New Heights.
Yeah, I was like just trying to think how would we check that, but we might have to think about it a little bit more to see if we can find like an example who would be pulled. Yeah.
Great. Shall we move on to department updates?
Sure. Dr. Shane, you're up first with adult dental updates.
Good morning, everyone. I am Barry Chang, the Medicaid Program Dental Director. A few updates on the dental side. There are over 23,000 unique members served up to date for dental service. And in the month of May and June, over 3,000 unique members seeing us a dental visit. And Olivia and I went to see the dental mobile van last Friday in Manchester. We want to talk to the care team, talk to the administrator, and really understand operation-wise what is the current situation and what is the plan. Overall, really positive feedback from the patient, and eventually looking at improving access, especially to the North County, because access in that region is really lacking. That's pretty much the update. Does anybody have any questions?
Any new providers added?
I don't think so. Since last month, I think we had a couple new providers. I don't think anyone in the last month, but I can double check. And then we did, the network has seen a couple departures from oral surgeons, which was unfortunate to see. We've added an oral surgeon in Massachusetts, or we're soon to. And neither of those departing oral surgeons were the ones most substantively serving the population, but of course it is definitely kind of the first notable loss in the network since the program start. So that'll be an area of focus for recruitment going forward. I also wanted to note, Joan, I know you had a question in the last meeting about dentures and long-term care residents, which we're working on some data there. We can share it over email or in the next meeting. Sorry, we don't have it ready for today.
we have talked to the dental mobile van vendor to explore the option of adding specialty care to their services, which I think would be a huge plus for the population.
Joan, did you have another question?
Yes, I did. Are there any plans being talked about, assessed for adding the CPHDH as a dental provider within the network?
Can you spell out your acronym for friends who don't know what that
Yes,
stands?
certified public health dental hygienist.
I think that
It's a
relies,
direct access provider, that's why.
yeah, I think it comes back to the who can be a billing provider in our Medicaid program without going through another billing provider. So that's, just to be totally clear, not something that the vendor, DentaQuest and Northeast Delta, can direct independently from New Hampshire Medicaid. Does that make sense?
No. However, I do understand perhaps there's a statutory process that could happen here, and
Exactly.
whether or not there's a capacity for this group to support that.
Yeah, okay. Yeah, so it's the same statutory situation as before, that, you know, hygienists are not independent billing providers for Medicaid.
Well, independent in New Hampshire.
In New Hampshire, yep, correct.
I believe it's 23 other states do that. So it's, I'm just trying to get a sense of what the support would be to add this provider, because I think they could make a tremendous difference in this population.
I think the team is not prepared to give an answer today, and I'm not sure it's fair to put them on the spot for something that impactful, but I'm sure they'll take it back and have a conversation.
I'm sorry, what I was trying to say, I don't think I was clear earlier, is that it would be legislative, like we would need a legislative change for that to change.
Okay, I was just trying to get a flavor of what the level of support would be. That's all.
We would be happy to
I
connect with you
understand the
separately on
process.
that. Yeah, more than happy to talk separately on that, Joan.
Okay,
Dia's hand up for a while.
Any thoughts as to why those providers left? Did they leave like New Hampshire as a provider? Did they just stop taking Medicaid? Any thoughts on that?
Yeah, it was two, practice of oral surgeons, although only two were actively seeing Medicaid patients. For those two, they cited like really transitioning career. They were both older, not to be like older, but you know, at a stage of their career where they're phasing down like days of actively seeing patients, and reducing just overall patient volume to spend more time with family. We did, through DentaQuest, have a lot of engagement with them one-on-one to try and probe, right? Like, were they having any claim submission issues? Were they dissatisfied with the reimbursement rates? This is a practice that set up a separate patient scheduling line for Medicaid patients to make sure they had the volume or the capacity to triage the incoming calls. At least in those conversations, their position was that it wasn't based on any of those factors. Reimbursement wouldn't make them stay. It was really just a shift in their careers. And I think this is something that we're trying to manage in general with the network, is just making sure we're wrapping around the providers, giving them as much support as we can to see as many patients as they can.
It's really great that you got all that info from them.
Well, and credit to Northeast Delta and their partner DentaQuest. It was really through the relationships that they've been building with the providers that we're able to kind of have these one-on-one interactions. Go ahead, Kelly.
Yeah, it's nice to get that information, but it isn't very telling.
Yeah.
And it leaves the question, it does. If there's no issues with this population that they would have, and the only reason is because they're going to reduce their work schedule, then what is it about the population that they're willing to keep that make them attractive enough to say, hey, I'm only gonna work a day a week, but this is the group I'm gonna keep? There's something there that we don't know. It can't be they're great, everything's fine, there's absolutely nothing wrong. But we're just gonna keep other people instead of this population. That makes no sense to me.
I think the fee schedule is always gonna be the major factor. The perception of no-show for the Medicaid population, that could be a problem,
I
but
think so too.
from what we have heard, no-show for the program, it's been really low. We're talking single digit, which is great.
Yep.
I think the claim process issues, I think that's more training and education for the support team, which Dental Quest could definitely do better. But I think the fee schedule, if you're gonna ask me, that's probably the number one factor. Compared on the commercial side, extraction of a wisdom tooth could be anywhere from $1,200. I think our fee was $5 something.
Yeah, and I think it's fair to say that and understand it and have that insight. It's at least more telling than, yeah, no, there's nothing that we would change. Everybody's fine, but we're not gonna take it. That does not make sense. So I appreciate that. Thank you.
But from those interviews Dental Quest did, they weren't getting that feedback.
Correct. Yeah, and I mean, I think what Barry's saying is more than fair. Like, it's, of course, the rates are there. But I think also at the end of the day, we're working with a very small network made up of individuals. And there is gonna be some nuance person to person.
Well, and I would just add, the comment about these providers, being in sort of the wind down period, the back nine of their career, so to speak. Half or more of New Hampshire's dental network is on the back nine. And we don't have a dental school, so we can't home grow any dentists. We have to import all of our dentists. And
Correct.
I think anybody who's lived around here long enough has had an experience where they lost a dentist at their practice, they got somebody who came, and either they or their family hated winter, and they lasted less than a year and went someplace else. So, the rebuild of the dental network for New Hampshire is, an urgent problem that you guys could have, comparable rates being paid, and people are still like, I'm tapping out because I'm 70 years old and I don't want to work anymore. So just color commentary.
I think on that a little bit, we're definitely looking into other possibilities, like maybe setting up more residency program. It would be a gateway for young professionals to enter into New Hampshire first as a resident. And if they like the area, they like the team, then eventually could be one of the regular. So we're looking at that as well.
Yeah. It just stinks that if you were born and raised in New Hampshire and you want to be a dentist, you have to leave the state to get your training. And we know that that's one big reason why we have an outflow of younger people is they go to school someplace else and they're like, I kind of like it here, and maybe the weather's nicer. So be that as it may.
And to also speak about dental hygienists, you can get your entry-level training here, but if you're going to do advanced training or dental therapy, you have to go outside of the state as well. And many times when that happens, they don't return. I've had now 5 years experience with the dental residency program at Harvard, and we have not been able to retain any of the residents that have come through the program so far. So we work very, very hard for that. And we're now working on a 2-year residency program to try to secure the work in the FQHCs. But you know, just for you to understand, that is an issue, and we're working very hard to change that. However, you know, so far that hasn't, and Harvard has not received any federal money since April. So we've had to go outside to get some funding to continue the residency program there. So, you know, there are always challenges, and we have to surmount and work with the challenges that are thrown our way. But I appreciate what you said about homegrown. We have so many dental schools in Massachusetts, and of course we have UNE, who was, you know, that was supposed to be a program, and I don't really know about. There are students that come over from UNE and work in the FQHC system. However, I don't know how many of them stay in New Hampshire. So, you know, it is a process for sure.
Gonna keep an eye on the clock. I assume it's more or less accurate today. Scott, what have you got to tell us about the DBU?
Yes, good morning. So real quick, because we are running out of time. So for right now, for the ending of June, we had 55 children cases pending, with 7 of those being over 90 days, 284 adult cases, with 13 of those being over 90 days. Of the 13, 9 were in the final stages of review and sign off, and 4 were still awaiting medical records. So kind of even with the month before, really, in the larger scope of things. If you scroll down to the next page, 68% of the adults have Medicaid through another avenue, be it Granted Advantage or other, and 33% of the children have Medicaid through another avenue. I did pull up, I wanted to do the first and second quarter. And as you'll see, the applications for January, February, and March remained at about 160 or so. We did see an increase in applications in April, May, and June, a little bit higher in the second quarter. So in the first quarter, January through March, our average days to processing were 64 days to process. And then April through June, 51 days to process. So well within that 90-day processing time frame. Our current timeliness rate is 95% of our cases are processed within 90 days, which is really good, because you're never going to hit 100%. We get, you know, this is counting for the delays that we're getting from the providers, not getting records, things like that, having to do multiple requests. So I'm very pleased with 95% process within 90 days. And certainly, you know, an average day to process of 51 is excellent. That's all I really have to report today. Does anybody have any questions?
Thank you.
Thanks so much. All right, so we're at roughly 10 of. I know there's been a lot of pent up interest about the HEE 805, and I know Brian has been here waiting patiently for nearly 2 hours. Can we do a highlights reel of some of the other updates, just so people are able to get their questions on 805 answered?
Yes, great. The DHHS roadmap is under development. We'll share it when the next iteration is released. On re-entry, I have a couple updates there. As of July 8th, total adults who are participating in the program are 88. 58 of those are active, 30 released. And for the youth, we have 9 currently, and 5 of those 9 are active. MCM contract, we recently had an amendment approved by GNC at the end of June. We linked that here in the agenda. If there are any questions, please let us know. HCBS spending plan, I don't have any updates since our meeting there. And on the list of waivers, I don't think we have any major updates to highlight on the 1115. Our 1915B for adult dental did get approved by CMS since our last meeting. And the Medicaid to schools contract was approved at the last GNC at the end of June, which we're very excited about. And so probably in our next August meeting or upcoming one, we'll share more on the vendor and how the kickoff meetings have been going internally, getting them set up and situated. And also we just had here linked the MEA vendor who was also approved at GNC. The link is there as well. I think those are the major updates to highlight.
Thank you.
Thank you. All right. So let's turn it to the HE 805. I know I saw Joan, obviously. I don't know if Kara and Carolyn are here. Kelly.
This is Kara, I'm here.
Hi, Kara.
Hi. I don't have anything else. I think that anything new, I think we were just waiting to see what updates Brian had.
Yes, so the department has taken back all the feedback we had from the last MAC subcommittee meeting. And we have another draft, which will be sent out along with an explanation of the changes that we made or declined to make, should be sent to the MAC subcommittee this week.
Okay, thank you, Brian.
When was our last meeting?
May.
I think it was May.
Okay. Thank you.
Okay, I'll wait for that and then I'll reach out to the rest of the subcommittee.
Any sort of teasers you could share, Brian, so people know what they're expecting?
So it's mostly going to be an explanation of some of the feedback that we got and why some of it won't be revised. But at other times we will be making revisions to align with what the MAC commented on. So I don't really have any more information right now.
But it's coming out this week.
Yes.
Excellent. Okay. All right. Anything on the HEM rules? It looks like approved, so we probably can take those off of our list, right?
We can remove those in the next agenda.
Okay, great. I think we've reached the end of our agenda. Okay. Any other sort of last comments or questions before we take a motion to adjourn? Hearing none, I see people already signing off. Don't forget, if you're a member, you can't leave until we adjourn. Was there a hand up or no?
Sam?
Hi everyone. Sorry, I have one more question. I apologize. I don't want to extend this any longer.
Go for it.
It's slightly unrelated, but some of the conversations we were just having about getting the word out to affected beneficiaries kind of brought back a question. It's not Medicaid related, but it's closely aligned in my opinion. One of the first shoes to drop with the federal bill that just passed is going to be the expiring premium tax credits for people on the ACA marketplace. I know that it won't be in any of the purviews of those of you in DHHS necessarily on the Medicaid side, but I just wanted to ask, I know many other states are working right now to get the message out to those who are going to be affected by the increased premiums on, for those who are enrolled through the marketplace. Is that something, to your knowledge, that's on DHHS's radar, getting out the word early about these new rates that are going to hit really, really soon, I believe as soon as the next open enrollment period?
Yeah, I know it's on the radar, and I know the New Hampshire Navigators may be a good connection to make there, because oftentimes some of the transitions when someone's going from Medicaid to marketplace coverage, they've been really helpful there, and I know they're working on communication campaigns and strategies as well. So I think that could be a good resource too.
One thing that's been on my mind in a similar vein, it's not squarely Medicaid, but it's sort of Medicaid recipient adjacent is all the changes to SNAP. I think there's just so much interrelation there, and access to food is a social determinant of health, so I feel like the impacts will be felt. So whenever we can weave that into our conversations, I would be grateful. Yeah, that makes sense. Okay. Anybody else before we take a motion? Right, can I have a motion to adjourn?
Wait, hold on, sorry.
Okay, what do we got?
Cheryl Frey wrote, I would like to know for next meeting what the issues or complaints are for the DentaQuest program. I am looking for specific complaints.
Cheryl, are you asking about like member grievances or some specific topic?
Yes, I'm looking for the complaints that are coming in from clients and how they're being resolved, and specifically what type of complaints are coming in.
Okay, yeah, we collect data on like appeals and grievances through that contract, so we could share that in the next meeting if that sounds
Yeah,
on.
I think it's really important to hear that.
Yep, absolutely.
All right, thanks so much.
Thank you.
Now may I have a motion?
So moved.
Thank you, Kelly. Do we have a second?
Second is Kathy.
Kathy, all in favor of adjourning, say aye.
Aye.
I'm not giving you discussion options for that. Thank you, everyone.